Okay, so to begin, I would knock on the door, make sure she's awake, because after the mothers have their baby, I was in the postpartum unit, and they told us that if they are sleeping, to just let them sleep and come back later, because it's more important that they get the rest. Like, doing a postpartum assessment could wait. So we'd make sure there's a response, so that we can let it rest. And so I'd go in, wash my hands, get all my supplies, clean my stethoscope, then address the patient and introduce myself. So, hello, my name is Zachary Presley. I'm a student nurse with TAMUCC, and today I'll be doing your postpartum checkoff. Okay. So, how are you feeling today? Good, glad, doing good. And then, do you have any pain? Is there any pain, like when the baby's breastfeeding, or any questions about the breastfeeding? And if they weren't sure about the breastfeeding, we could ask them to hit the call light whenever the next time they are going to breastfeed, so that we can watch, make sure the baby's jaw is moving and they're like actually getting the food. So if there's no pain, we'd go ahead and assess just like a general psych assessment to see how the mother's like beginning to transition from caring about herself to caring about the baby. So do you how is your baby? Good. Have you all got a name for it? No? Okay, the name, all that stuff. And so then we'd go ahead and transition into getting vitals, the blood pressure, pulse, the heart rate and all that, and then temperature, blood pressure, pulse, all right. I'm missing one. Oh, and the respirations. Make sure that the respirations are good after the anesthesia and all that. And so we just expect all of the vitals to be within the normal range, so that we don't have to so then go ahead and do all of the things that require auscultation. So I'd assess the lung sounds. Can you go ahead and take a deep breath for me? Okay, and then another one. And then, okay, sounds good. Okay. And then, while we're already auscultating, do the heart, the aortic, then pulmonic, side pulmonic, the apex, tricuspid, and the mitral. And then go ahead and auscultate the bowel sounds, starting with the left lower, left upper. Okay. And then, obviously, I can't pick up my pillows and then get them back, so we would listen to the lung sounds on the back also, and assess for the CVA tenderness to make sure that their kidneys are okay. And it's important to make sure that the bowel sounds are present, and inspect the C-section if they had one, to make sure the suture line, well, they use glue now, but make sure like everything's okay, there's no bleeding. And then it's important to make sure that they're active bowel sounds because of the anesthesia, because it can cause, it suppresses everything. So we want to make sure that they're getting bowel movements and stuff again. And then go ahead and ask the patient about her diet. So what did you eat, like get a baseline before, like what were you eating? And then, now that you're going to be breastfeeding, similar to when you had the baby, it's recommended to eat 300 to 500 more calories than you already were, so that you can have the nutrients for the child. And then, it's the activity level is good. She reports a good activity level. So that was all the vitals. But whenever we're assessing the vitals, and like especially when we're down in the abdomen, looking for the striae lines, and then the linea nigra. The linea nigra in the striae, and then I don't know how to pronounce the word, but the pregnancy mask, it's like cholosoma. I don't know how to pronounce it, but yeah. Okay. So then we would begin the bubble U mnemonic, starting with the breast. I'm a guy, so I don't know how open most mothers would be to me doing this part, but since we're learning, I'm gonna do it anyways. I'm just gonna pretend like they would, just assume consent. But obviously, if I was in the hospital, I would ask first to make sure they're okay with me, especially with the lochia and the breasts and all that stuff. We assess the breasts for, so to assess her breasts and her nipples to see if the breasts are full, filling, or if they're soft. Like in the video, in the checkoff video, it said 3 days after you'd expect them to be full. So we want to see if they're soft or if they're full of milk, and then checking the nipples for redness, swelling, or cracks, which would be abnormal findings. Want to make sure that there's no pain when the baby latches for feeding. Make sure the baby's getting the nutrients it needs and the mother's comfortable. Yeah, so that's the first V, and then the U. It assess the patient's uterus. So I'm going to assess your uterus. So one hand on the pubic symphysis, and then one pressing to feel the uterus. And then, so it should be midline at the umbilicus, and it shouldn't be boggy. It should be firm so we can feel it. And it's important when I'm checking her uterus to see if it's midline and at the umbilicus, because if it's deviated and not midline out here, then that takes us to another B for bladder. That would be a sign that, like, we want to make sure that she's, when she does use the restroom, she's peeing in the hat so we can measure it. Like if she's going too many times, but there's not a lot of urine being produced, then whenever she goes not being produced, there's not a lot of urine in the hat after she goes, we can tell that there's some abnormal function there. So if the uterus is not midline and at the umbilicus, then we know that there's a problem with the bladder, and then we can confirm it with the hat. And then whenever we're like palpating the uterus, we're also looking for the lochia to see if she's producing any clots, especially if the uterus is boggy, because that'll be a sign that it's not healthy and we have some problems. So when we see the lochia, so that's all for the uterus. I think I can go ahead and transition to the lochia. Oh yeah, we hold the symphysis so that we don't push the uterus out, because that would be bad. So when we get lochia, we're assessing it for odor, color, consistency, and the amount. So we do that, and then clots too. Clots are a big one. And then we roll the patient over and use the pen light under the buttocks to see if the patient did have an episiotomy, to make sure that everything looks like it's healing okay. Ask about pain with it. So I go over and ask if she has pain or pain from hemorrhoids or anything. So, so your uterus was midline and at the umbilicus, so that means that we're doing good with the uterus. Lochia, normal color, no foul odor, no abnormal consistency, clots or anything, normal amount. And then we rolled her over. There was no blood on the bed, so she wasn't a quiet bleeder. And then bladder was good, uterus was good. Breasts, there was no, breasts were still soft and like still not to the point where they were full. With nipples, no cracks or bleeding. There's one more thing. Oh, and then the other B for the bubble would be the bowels. I skipped that one. I went straight to bladder and lochia, but we already listened to the bowel sounds, so they were active and good. So no bleeding, no abnormal lochia. Uterus is good. The episiotomy, that one's if they had one, and yeah, we looked and everything was good now. So then I would transition to Homan sign, which I'm going to do last because I'm going to have to, well, I guess I could just pretend like this is her leg. So I'd hold her leg and take the gloves off and have her calf and feel for, watch her, like, is it okay if I feel your calf? Yes. And then when I'm feeling it, assess her, like, for any grimacing, for tenderness or anything. And then also feeling for heat. to assess for a deep vein thrombosis, the DVT. And so then I'd hold it and then do the reflex on the knee, looking for a 2+ reaction, and then checking for dorsiflexion of the foot at the ankle, make sure everything's good there. The helmet sign. Yeah, I'm just making sure I got everything on that before I assess her psyche. Okay, I got everything on that. So I'm gonna do an assessment on her psyche based off the questions that Professor Harrell used. It's important that we do make sure that the mother is transitioning from that caring about herself and like the pain from the pregnancy and all that to transitioning into caring for the baby, because we want to make sure that the baby is going home to like a mentally sound mother, because it is a lot of work to take care of the baby. So we want to make sure that it's going to be a long road. Like if they're already having trouble now, it may be important to talk to them about postpartum depression so that we can get them started on some type of medication that would help them before the problem causes something for the baby, because we care about the mother and her health and her mental health, but we also care about the baby, so we want to make sure that the baby is in good hands too. In this part of the assessment in real life, obviously, if the father is there, we want to assess him too, include him in some of the questions to make sure that he is okay mentally too, even though the woman carried the baby, sometimes the guys have a hard time too. So throughout the assessment, I was assessing her for her psyche, like her response, making sure she's making eye contact with the baby, making sure she's caring for the baby and like putting the baby before her type of thing. So I'd ask, have you came to a name for your baby? Whenever you're breastfeeding your baby, does it hurt? And then like just if her baby's like going to the warmer or like to whatever, the nursery, like assess her whenever that happens, like how she reacts and like her wanting to see the baby, wanting to hold the baby, wanting to be with the baby, that type of thing. And if there are signs that she is struggling with her connection with the baby, then we want to do a more extensive interview and maybe notify the healthcare provider that she could be like experiencing a type of postpartum depression. Once again, so we can get it before she leaves the hospital. So don't want to send the baby home with a mother who isn't fit to care for the baby. So let me look over my thing, make sure I didn't miss anything. Oh, whenever we're assessing the DVT and the legs for the Homan sign, we also want to check, while we're down here, check for edema. And so, because they get a lot of fluids, especially if they had an epidural and stuff, they get a lot of fluids through an IV. So they will have edema. So like over whatever the hospital's like rules are, like was it 48 hours or 24 hours, the time that we're with them, we want to see make sure the swelling goes down, make sure the fluid goes down, make sure all this stuff, so that and that goes hand in hand with the bladder, making sure that her body is like her intake and output. She's taking fluids in and staying in good health, but she's also getting fluids out so that she doesn't have edema and swelling and stuff. I want to make sure that she transitions good. So assessed the bubble heat, assessed all of her vital signs and stuff. And I actually got to do this in the hospital with my nurse for the clinical. It's hard doing it in front of a camera. It's funny how it's more stressful to do it in front of my phone than it is with a patient. But it was pretty cool. So, especially the emotions part. I didn't know going in that there was so much like emotional assessment after having a baby. It makes sense, but you don't really think about it until you learn about it. So.